Well, it's 9 o'clock, so I think we should get started. Welcome everyone to the 8th annual Kushner AAPOS webinar. My name is Leah Reznick, and I'm the director of the Elks Children's Eye Clinic at the KCI Institute in Portland, Oregon. I am honored to have been selected as the moderator for this interesting and valuable conference. This webinar was organized by Dr. Burt Kushner's former fellows to celebrate his contributions to the field of ophthalmology, and specifically strabismology. The Kushner Award is selected by the members of the University of Wisconsin Pediatric Ophthalmology Group and a member of the AAPOS Board of Directors. Their charge is to pick an experienced and well-organized member of our field to provide practical information to improve patient care. We definitely have that today. I am really excited to learn more from these 4 smart, thoughtful, and engaging speakers. Before we jump in, I want to share some logistical information. Dr. Pineles will introduce each of the panelists, and then each of the panelists will give their talk. And if you have a question during their talk, please write it in the Q&A section of the meeting. Each of the lectures will be for 15 minutes. There will then be a 5-minute question discussion session with the panelists. Dr. Pineles will then give the Kushner Lecture, followed by comments by Dr. Kushner. If there are any issues or problems, please let us know in the chat, and remember to put your questions in the Q&A. Thanks, Dr. Pineles.
Hi, everyone. Thank you so much. And thank you, Dr. Reznick, for that organized introduction so everyone knows what to expect. I am going to introduce our first speaker, who's on the next slide. I want to just start by explaining the goal of the speaker choice that we had today. As some of you who know me know that I'm a pediatric neuro-ophthalmologist, and I love to learn and think about pediatric neuro-ophthalmic disorders, especially in the context of strabismus. And so I chose 3 dual-trained pediatric and neuro-ophthalmology specialists who each have a special area of expertise with the intersection of pediatric neuro-ophthalmology and strabismus. And I admire all 3 of them and know them all really well, and I'm really excited for all of you to hear their talks. So I'll start by introducing Gena Heidary. Dr. Heidary is an associate professor of ophthalmology and the founding director of the Pediatric Neuro-Ophthalmology Service at Boston Children's. She's also the fellowship director for the Pediatric Ophthalmology Fellowship, which many people think is one of the top few fellowships other than UCLA. The 2 fellowships she did were both at Mass Eye and Ear and Boston Children's Hospital. You know her name because she's served on the author of many, many publications, book chapters. She gives lectures all around the world, and she's the editor of the first case-based textbook in pediatric neuro-ophthalmology. She provides a lot of services to AAPOS and the Academy, and we're just so lucky to have her in our field, and I can't wait for all of us to hear her talk. So let's go ahead and hear from Dr. Heidary.
Good morning. Well, thank you, Dr. Pineles, for such a lovely and generous introduction. You are a tremendous leader in our community and have made so many contributions. Congratulations on receiving this award. It is so well deserved. You're a dear friend and colleague to us all. So yes, I'm really excited to share with you my experience in thinking about the interplay between brain tumors and oculomotor function. And I think, I'd like to talk a little bit about our experience at Boston Children's, and hopefully this will give you food for thought for future considerations and future projects. So just to provide a little bit of framework about pediatric brain tumors, cancer itself is the lead cause of disease-related death amongst children in the United States. And solid tumors are only secondary to leukemia as the most common tumor that children experience, accounting for about 25% of tumors in childhood and adolescence. What's encouraging is that the survival rate for cancer, pediatric brain tumors, has improved because of molecular characterization and biological characterization of these tumors, which make them more amenable to treatments. But now this means that we're going to see more of the sequelae and morbidity after treatment including visual morbidity. So a lot of the late effects of these brain tumors are manifest in a number of ways that we see. Some of it is with respect to visual dysfunction and other with respect to diplopia. And this may be related to where the tumor was and how it was treated either surgically or with chemotherapy or radiation. The childhood cancer survivor study examined and compared children who survived pediatric brain tumors as compared with siblings and found that there's a higher risk of legal blindness, diplopia, and cataracts after surviving brain tumors as compared with siblings. And we know about these different mechanisms of visual dysfunction. So there are many things that impact vision and visual field. We see compressive or infiltrative optic neuropathy. Patients will have hydrocephalus and papilledema that leads to optic atrophy. We may see iatrogenic visual field loss from surgical debulking of tumors or from just the tumor presence along the visual pathways. Some of these children will be treated with radiation, and also will have cranial neuropathies that cause exposure keratopathy or neurotrophic keratopathy. What we're going to focus on is efferent dysfunction. So what is the nature of strabismus that occurs in association with these tumors? They may take the form of cranial neuropathies, sensory strabismus, strabismus secondary to visual field loss, and also many of these kids will have nystagmus. I'm particularly interested in tumors in two particular locations, in the dorsal midbrain and posterior fossa, and I'd like to explore outcomes with you today. The purpose of understanding motor outcomes and the potential for postoperative fusion and stereopsis is twofold. Part of it is, of course, to be able to provide counseling to our families and offer excellent care. You know, what is our expectation if we do strabismus surgery? But I think understanding these outcomes also may inform us in understanding kind of neuroanatomy more effectively, and also the resilience of the binocular system. You know, what types of trauma to the system allows it to persist, or you know, irrevocable changes that we can no longer restore binocular function. So let's first focus on the dorsal midbrain. It's one of my patients I've seen for many years with a non-germinomatous germ cell tumor who has very classical features. He has eyelid retraction or Collier sign, an exotropia. He has convergence retraction nystagmus, attempted upgaze, and this is from the tumor in his dorsal midbrain. But the data regarding strabismus outcomes are limited. We have some information from the neurosurgical literature that suggests that regardless of tumor treatment, strabismus and the dorsal midbrain findings persist. So they're not really a gauge of tumor treatment and can't be used long-term in terms of management. There are some excellent studies discussing the surgical management of upgaze paresis from Duke and also from Dr. Brodsky. And then a case series of two patients talking about central disruption of fusion from our group, Dr. Hunter at Children's. And I want to provide you two contrasting cases for your thought and you know, to frame our discussion. The first is a 10-year-old with a pineal tumor. He underwent standard treatment, surgical debulking, treatment of his obstructive hydrocephalus, chemotherapy, and radiation. And he developed a convergence insufficiency type exotropia. Preoperatively had gross stereopsis, moderate angle of an exotropia of 30 at distance and 45 prism diopters at near. And his surgery was relatively straightforward. I performed lateral recessed procedure on the right eye, and postoperatively, although we would say that his motor outcome is not successful by the definition of less than 10 prism diopters horizontally, he did have postoperative fusion and stereopsis. This contrasts with an 11-year-old boy whom I've treated with a pineal tumor and a similar treatment, surgical debulking, chemotherapy, and radiation with a basic exotropia. And postoperatively, his angle was reduced from 20 prism diopter exotropia to 2. And in spite of excellent motor outcome, he has no stereopsis or fusion. So we performed a retrospective case study of all of our patients we've seen at Children's to try to explore what are the outcomes and understand our expectations more effectively. And this was done in collaboration with my two neuro-ophthalmology colleagues, Ryan Guys and Eric Geyer, and our excellent fellow, Margot Weinert. So we identified 35 patients with dorsal midbrain syndrome, the majority of whom were under 18. And in this cohort, the majority of patients had pineal tumors and underwent surgical debulking and some treatment of hydrocephalus. As consistent with other case series looking at features of dorsal midbrain syndrome, most patients will have at least upgaze paresis, which is the case in our cohort, and about half had convergence retraction nystagmus. 91% of our patients had some form of strabismus. What's interesting here is, what are we expecting? So I think I was anticipating that our children would have more vertical misalignments, but in fact, the majority had exotropia, and in particular, the majority of these patients had a convergence insufficiency type exotropia, which really speaks to the location of where these, the location of the dorsal midbrain and its interplay with the near triad. And so I think it's interesting, these data are not robust enough to analyze, exactly, where is the convergence center, what has been impacted, nor do they allow us to sort of evaluate what is the interplay between convergence and accommodative dysfunction. But I think these are very interesting things to consider in the future. Most of our patients had standard surgery and fairly heterogeneous approach, either recess resect or BMR resect or BLR recess. And in terms of motor outcomes, actually, it's quite favorable, where there was a statistically significant improvement in the horizontal deviation. And if we focus on just a summary of motor outcomes defined as shown here, 67% had excellent motor outcomes, and only a few required reoperation within the first year. But when we look at stereopsis and fusion, this in comparison was less favorable, with 2 of our patients ending up with central disruption of fusion. So in the dorsal midbrain, convergence insufficiency was the most frequently found strabismus type, and it's quite amenable to surgical treatment. We achieved motor success in 67% of our patients, but when counseling our patients with respect to the potential for binocularity, our outcomes were less favorable. And one of the things that I think that I do in my practice, and I think likely many of you do as well, is in preoperative planning, I examine these patients using the synoptophore, because I think that this is a very helpful tool for us to try to predict in whom we may see more successful outcome with respect to binocular function. Central disruption of fusion happened in 2 of our patients in the cohort. And, again, it's a small group. It's 35 patients. Although this preoperative assessment with the synoptophore gives us some insight into those patients who may be less likely to have good binocular outcomes. I do think that accommodative dysfunction contributes to successful outcomes, and I'd like to evaluate this in the future. Some inkling that concurrent visual field loss may contribute to our poorer outcomes, and in particular because many of these patients will have homonymous visual field deficits, which themselves can contribute to exotropia more frequently than esotropia. And then finally, the question of torsion and how this may contribute to outcomes needs to be evaluated. So let's go further back to the posterior fossa, which offers, it's a different location and kind of a different characteristics. Let's take a look. These tumors represent the majority of childhood CNS tumors, and they range from those that are uniformly fatal, diffuse intrinsic pontine glioma, to those who have more favorable outcomes, like a juvenile pilocytic astrocytoma. We have minimal data on sensorimotor outcomes. There was a wonderful study from 2000 from Mike Repka and colleague looking at 23 patients with majority of posterior fossa tumors and found that, interestingly, there was potential for resolution of strabismus, in whom 60% were orthophoric at the end, at the most recent follow-up, and a good number of patients with stereopsis. So that's very interesting. And let's present two cases, contrasting cases. This is a young girl whom I saw who presented with a 6th nerve palsy in the setting of diffuse intrinsic pontine glioma. And as I mentioned, it's uniformly fatal, but her family was quite interested still in strabismus treatment because her diplopia was intractable and really contributed to poor quality of life in the life that she had remaining. So at first I was more conservative and just did Botox, which really didn't do much to her esodiation. And then she underwent surgery, including superior rectus transposition, with excellent postoperative result. She had just a trace head turn, she had no diplopia, and she had stereopsis. And this was really very important to her family and the last months of her life, to have good quality. And in contrast, this is a 3-year-old with an ependymoma who had surgical debulking and radiation and postoperatively developed a 6th nerve palsy. But interestingly, her cranial neuropathy resolved without surgical intervention. So in collaboration with Dr. Edmond, when she was at Texas Children's, we pooled together our patients who had posterior fossa tumors to really examine what is our expectation for surgical success when we treat our patients for strabismus. And together we found 127 patients, of whom the majority had medulloblastoma. And interestingly, in contrast to those children with dorsal midbrain tumors, these children had predominantly cranial neuropathies. Some presented with these as the initial feature of their tumor, including 6th nerve palsy, 4th nerve palsy. And then post-surgical debulking, typically many of these patients developed either isolated cranial neuropathies or multiple cranial neuropathies. So 3rd, 4th, 6th, or a mixture of these, with a total of 44% having strabismus. So this is quite interesting to me. In contrast to those patients with dorsal midbrain syndrome, in the posterior fossa, there can be spontaneous improvement of the strabismus. And about half of the cohort had resolution of strabismus, particularly those who had 6th nerve palsy within the first year following the onset of strabismus. And if we look at our postoperative outcomes, they were quite favorable, with 45% showing good motor outcomes and about 1/3 with good stereo acuity. So in the posterior fossa, ocular motor dysfunction is common, including strabismus and nystagmus, but many of these patients will have strabismus that resolves on its own without intervention. If we do intervene, we have the potential for good outcomes. And again, here we want to explore what is the relationship between this and visual field loss, and also how does nystagmus kind of confound our ability to achieve good motor outcomes. To summarize, I think as strabismus surgeons, these results and our exploration of our children has been very encouraging to me. I think we can counsel our families that successful motor alignment can be anticipated in tumors involving the dorsal midbrain and posterior fossa. I think we have to be more guarded about the potential for binocularity. And then further, I think in the future, we can expand on understanding outcomes within the context of quality of life measures to better understand the impact of these tumors on function. Thank you so much.
That was great, Dr. Heidary. Thank you so much. And for those of you just joining, I have a pretty bad cold, so sorry for my voice. But luckily for you, my talk is recorded, so you won't have to hear much more of this. It's My pleasure, and I'm just so excited to introduce Dr. Melinda Chang. If you don't already know her, you will soon because she's a rapidly rising star in our field. She's another dual-trained pediatric and neuro-ophthalmologist. Both of her fellowships were done at UCLA. She's currently the founder and director of the Autism and Neurodevelopmental Disorders Research Group and is an assistant professor at the USC Roski Eye Institute and Children's Hospital of Los Angeles. In her career, which is not as long as mine or the other panelists, she's already served as an author on 57 manuscripts, 3 book chapters, 18 invited lectures, several international lectures. She has a lot of service already to AAPOS and AAO. Last year or the year before, she had the most cited article in the Journal of Neuro-Ophthalmology. She is doing the whole world a favor by focusing her research interests on CVI, which is an increasingly prevalent and important disorder that none of us really know how to manage or treat. And so we're all so lucky, and the patients are extremely lucky that she's chosen this to be her area of interest. And so I'd like to introduce Dr. Chang, who will speak about CVI.
Thank you so much for that kind introduction and for inviting me to give this talk today. I am again so excited to speak to you about CVI, which is one of my favorite topics. I'll be talking about new directions and strabismus outcomes. These are my financial disclosures, and here's just a brief outline of what we'll be talking about today. We'll just get started with the background. So CVI traditionally stood for cortical visual impairment, but the terminology is a little bit controversial, and many people now call it cerebral visual impairment because we know that the white matter tracts are often involved. And now some people are actually calling it brain-based visual impairment to just be a little bit more accessible to patients and their families. I'll be using the abbreviation CVI for this talk. So CVI is the most common cause of visual impairment in children in developed countries, accounting for about 18 to 48% of children who receive services for being visually impaired or legally blind. It may actually be underdiagnosed in special needs children. So there was a study last year out of the UK showing that about 30% of children who required extra educational help met their definition of CVI. So the definition of CVI is also a bit controversial, but the most widely accepted definition is that it's a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. More traditionally, CVI referred to patients who had subnormal visual acuity or visual field loss caused by damage to the postgeniculate visual pathways in the brain, but there are some patients who are diagnosed with CVI who have normal visual acuity and normal visual fields and who just have visual perceptual problems. A CVI, as you know, can be caused by any type of neurologic problem that can affect the visual pathways in the brain, most commonly hypoxic ischemic encephalopathy or prematurity with periventricular leukomalacia. It can also occur in the setting of trauma, hydrocephalus, infections, metabolic or genetic disorders, which are increasingly recognized, structural brain abnormalities, seizures, especially infantile spasms or types of seizures that can cause epileptic encephalopathy, as well as in utero drug exposure. Now, children with CVI seem to see differently than children who have ocular causes of visual impairment, like cataracts or ROP, due to involvement of the brain pathways, the visual pathways in the brain. So first of all, they tend to have variability or fluctuation of their vision. So their vision can be a lot worse if they're in an unfamiliar environment or if they're sick or tired. There's also a very consistent crowding effect where they have a lot more difficulty seeing an object on a crowded background versus on a plain background, like in this example here. Color vision tends to be relatively spared, which is thought to be due to bilateral representation of color. Contrast acuity may be selectively affected. They might also have blind sight, where they may not be able to see an object while it's still, but they can see it while it's moving. Many of them have increased saccadic latency, which means it takes them a longer time to respond to something that they see to make an eye movement towards it. Of course, depending on which part of the brain is involved, they may have visual field defects, and often they have an eccentric gaze preference. They tend to look away while they're reaching for something. We're not exactly sure why this happens, but it may be due to the use of their residual visual fields. And finally, a lot of them tend to prefer to gaze at lights, so they stare at the overhead ceiling lights, but some of them paradoxically have photophobia. Now, in those patients who are sometimes called cerebral visual impairment or high functioning CVI, who have visual perceptual problems, some of the things that have been described include simultaneous agnosia, or problems with seeing more than one thing at once, akinetopsia, problems with motion perception, astereocognosis, problems with depth perception, topographic agnosia, problems with visually guided orientation, as well as prosopagnosia, or difficulty with recognizing faces. So how do we diagnose CVI? Well, again, this depends on the definition. So the definition is, again, a verifiable visual dysfunction, which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. So the second part is easy. This just means that the vision loss is worse than would be expected on the eye exam. Many of these patients have mild optic atrophy, but the vision is worse than you would expect based on the optic nerve appearance. The first part is a little bit more tricky because a verifiable visual dysfunction could mean different things to different people, and it's sort of intentionally vague because of the sort of controversy regarding CVI diagnosis. But we know with these patients, we definitely need to assess two things. First of all, their visual function, which is their visual acuity or their contrast acuity, or the things that we normally test in clinic. And then we have to assess their functional vision, which refers to how they use their vision to do their everyday tasks. This is because kids with CVI often have worse functional vision than would be expected based on their visual function. This picture here just shows the sort of classic toy box example where children with CVI may have a lot of trouble finding a toy in this toy box because it's so cluttered. So a lot of the research right now surrounding CVI is based on how we can best diagnose and assess CVI. There's a lot of different methods to assess both visual acuity as well as other visual characteristics in CVI. We know that visual acuity doesn't tell us the whole story, so we want to focus on methods or supplement them with methods that can assess other visual characteristics. I'm going to be talking today about eye tracking, which is where a lot of my research is focused. If you want to hear about these other methods, you'll just have to come to our AAPOS CVI workshop. So here is a picture of our eye tracking lab, for those of you who aren't familiar with eye tracking. So this is a computer monitor, and on this computer monitor, you can show whatever you want. Here we have a grading on a luminance match background, which is pretty much the same as like a teller acuity card. On the bottom, we have the eye tracking camera. So it uses infrared light to look at the corneal and pupillary reflexes from each eye. And using that, it can determine the direction of eye gaze with very high accuracy, less than 1 degree error. And we record at a high frequency, about 500 hertz. So depending on what you show on the computer monitor, you can assess a variety of different visual characteristics. Some of the things we're looking at are visual acuity, contrast sensitivity, color saturation, oculomotor parameters like saccade latency, motion perception, crowding, or visual field defects. But I do want to talk about how eye tracking is used across the country in children with CVI. So there are 3 labs across the country who are doing this type of research. The first one on the left is led by Glenn Presky at Cornell, and he's looking at kids with CVI who have traumatic brain injuries and looking primarily at ocular motor function as well as saccade and pursuit distribution. In the middle is our lab. We're looking at younger kids, often neurodevelopmentally delayed, and we look at psychophysical measures as well as visual attention. And then on the right is Lotfi Merabit's lab at Boston Children's, and he is primarily evaluating older children, like teenagers or young adults with CVI who are more high functioning. They often have a visual acuity of greater than 20/80, and their cognitive function is not as compromised, so they're able to do tasks that require cooperation, such as finding a toy in a toy box, as here on the top, or finding a person in a hallway here. So the same technique can be used for a lot of different purposes and in a lot of different populations, which is great for CVI because it's so heterogeneous. I want to tell you a little bit about how we're using AI to analyze our eye tracking data. And to do this, we're using something called saliency, which is a computer vision model which predicts fixations based on stimulus features. Here we have one example, which is the Deep Gaze 2 saliency model, which predicts features based on attention based on objects or people which are in a picture. So we feed the model this picture here, and we can see based on the model, it predicts that the salient aspects with regards to objects and people are these 2 people's heads here, as well as this slide. And then we show this picture to control patients as well as CVI patients and have them undergo eye tracking, which generates these heat maps. In these heat maps, the fixations are shown and the areas where there's longer fixation are red. So you can see the heat map of the controls is quite similar to the deep gaze saliency model, where this is child with CVI, then the heat map is quite different. They seem to be focusing more on these vertical lines in the background or on the playground. Then when we compare the eye tracking maps to the saliency maps, we can develop these saliency traces. So here, over the 1 second period that we're showing the picture, you can map the exact saliency value of whatever pixel they're focusing at any point in time. These are just saliency traces of 9 different patients with CVI looking at the same picture. And then finally, we can use a technique called dynamic time warping to compare patients with CVI versus controls. So in this matrix, each column and each individual row represents one subject. The CVI patients are on the top and on the left, and the controls are on the bottom and are on the right. And each subject is compared to all the other subjects. And each square shows how similar they are to one another. So darker means it's more similar. If a person's compared to himself, then they have perfect correlation. Here you can see that the controls have very similar patterns of eye tracking when looking at the stimulus, whereas there's a lot of difference between the CVI patients and controls, and also a lot of heterogeneity among the CVI patients. And the nice thing about saliency is that we can, depending on what model we can use, we can look at different aspects of the image and see what aspects actually are most discriminative of patients with CVI versus controls. So again, that initial model that I showed you, the deep gaze model, is focused on objects and people, but we can make saliency maps for color, gradients, orientation, other types of things. And here is just a flow chart of how we are planning to quantify saliency using eye tracking in children with CVI. So again, we start with a stimulus, we develop the saliency maps as well as the eye tracking fixation maps, and then we compare them using the saliency traces here. With the saliency models, we can do not just the object-oriented model like I showed before, but other things like color, contrast, orientation, and intensity. And for each of them, we can develop these dynamic time warping graphs to compare the children with CVI versus the controls. So ultimately, for each child with CVI, we'll be able to compare their eye tracking trace to the controls on all these different models in order to get a saliency score for all of these different visual characteristics. And then ultimately, hopefully, we'll be able to combine them all into an overall saliency score. So we hope that this CVI eye tracking severity score can be used as an outcome measure and for future clinical trials of CVI. These scores are just representative. We haven't done them all yet. This is just our plan for the future. So I want to shift gears a little bit and talk about management of ocular comorbidities in children with CVI. So as a pediatric ophthalmologist, management of the ocular comorbidities is one of our main jobs in kids with CVI. So they frequently have refractive errors, strabismus, optic atrophy, and nystagmus. Some of them have oculomotor apraxia, in which case they wouldn't be eligible for eye tracking. Also, some of them have congenital optic nerve anomalies. In terms of strabismus, my partner Mark Burt did a study a few years ago looking at our cohort of patients with CVI, and I want to draw your attention to a couple of the findings. The first is that 16% of them actually had spontaneous resolution of their strabismus. So as their vision improved, their strabismus actually resolved. Most of them had a constant XT that became intermittent and eventually went away. Of the patients who underwent surgery, about 56% of them had good horizontal alignment, which we defined as less than 10 prism diopters of deviation. So it is a lower, I guess, percentage of success than we would think of compared to sort of neurotypical patients, but it did help the majority of patients who underwent surgery. Next, we were interested in looking at the effect of cerebral palsy. So about 50% of kids with CVI have cerebral palsy, and cerebral palsy has been shown to be potentially impactful on the outcomes of strabismus surgery. So we did this retrospective study of outcomes in children with CVI with and without cerebral palsy, and then we looked at their strabismus outcomes. A good outcome was considered, again, a horizontal deviation of less than 10 prism diopters. Now, in our practice, we typically offer surgery to patients who have a stable deviation, good control of their underlying condition, neurologic condition, and visual acuity of at least level 3 on a 6-level scale. I know I didn't go through the whole scale here, but that corresponds to being able to fix and follow large objects. So in this study, we included about 300 patients, half of them with CVI and half of them without cerebral palsy. And here are some of their baseline characteristics. You can see strabismus was very common, occurring about 70 to 80% of the patients with no difference between the two groups. Most of the patients had exotropia, although about a third of them had esotropia. And then when we looked at their final alignment at the last follow-up, we see that the percentage of patients who had good alignment, less than 10 prism diopters of a horizontal deviation, didn't differ between the groups, and it was fairly low overall, between 40 and 50%. However, when we looked at the subset of patients who underwent strabismus surgery, which admittedly was a small subset, we do have this interesting finding. So initially, postoperatively, there was not that much difference between the groups, but after about 8 to 10 years, there was a great deal of divergence where the children with CVI and cerebral palsy, almost all of them ended up with a poor surgical outcome, again, meaning that they had a horizontal deviation greater than 10 prism diopters. And this was about equally divided between those who had recurrent or residual strabismus and those who had consecutive deviations. So in patients who have CVI as well as cerebral palsy, their long-term strabismus surgery outcomes may be worse. So in terms of future directions for CVI research, I think most people in the field agree that we need to have a standardized definition and terminology of CVI so that our studies will be comparable. We also need to have standardized diagnostic criteria based on validated measures of visual function and functional vision. Prospective longitudinal studies of outcomes are important because our retrospective studies show that there is a considerable rate of spontaneous improvement of vision, and we need to know what that rate is prospectively in order to be able to compare it to patients who undergo interventions, because our ultimate goal is to do clinical trials of interventions for CVI. So in summary, CVI is a common cause of pediatric visual impairment and may be under-recognized. Assessment of both visual function and functional vision are important in children with CVI. Application of artificial intelligence to eye tracking may yield an objective and quantitative measure of CVI severity. Considerations in children with CVI and strabismus include spontaneous resolution, as well as the potential impact of cerebral palsy on surgical outcomes. And finally, what I think is the most important thing to get out of this talk is that a lot of work is needed to prepare for future clinical trials. I'd like to thank Dr. Kushner and Dr. Pineles, as well as all of my mentors and collaborators and the whole research team, without which this wouldn't be possible. Thank you.
Thank you, Dr. Chang. That was really wonderful. Yeah, I'm so excited to see what comes out of your research on CVI. Our last speaker is Dr. Jane Edmond, who is our third of the 3 speakers who has trained dually in both pediatric ophthalmology and neuro-ophthalmology at the University of Iowa and Baylor College of Medicine, respectively. Dr. Edmond is the Wong Family Distinguished University Chair and Professor of the Dell Medical School at UT Austin, and she's the director of the Mitchell and Shannon Wong Eye Institute. She was the original chair. She created this department and residency program, and that's a really big job. So I'm in awe of her for many reasons, including that. Everybody knows her. She's served as an author on over 50 publications, 12 book chapters, multiple national and international lectures, and she's a frequent keynote speaker and visiting professor. We all know her well because she was president of AAPOS and is the president-elect of the Academy to serve as president in 2024. We're so lucky she made the time for us, her little pediatric ophthalmology people, to hear from her about craniosynostosis. Thank you so much, Dr. Edmond. We're so excited for your talk.
I'd like to thank Stacy and Dr. Kushner for allowing me to speak in this 8th annual Kushner webinar. To be associated with these amazing women of pediatric neuro-ophthalmology is a great honor and gives me great happiness. Stacy, congratulations on being chosen for this 8th annual as the Kushner Lecturer. And of course, everyone knows Burt Kushner, a legend in our field that has changed how we view strabismus and how we manage it. So Burt, thank you for your generosity in establishing this webinar and your vision. So let me kick it off with the management of strabismus in association with craniosynostosis. No relevant financial disclosures. And so first of all, what kind of strabismus is associated with craniosynostosis? Well, we see horizontal deviations, ET, XT, but it's the vertical deviations that are the most vexing for us to treat. And it's namely over elevation of the eye in adduction. It's secondary to true and pseudo inferior oblique overaction. So it's more appropriately termed over elevation in adduction, but you know, it's a lot easier for us to say IO overaction. It most often occurs on the side of the fused coronal suture. So in this child with Cruzon syndrome, patient had over elevation and adduction bilaterally, but so it most typically occurs on the side of the fused coronal suture, but in a unicoronal situation of fusion, it can occur on the normal side as well, because the normal orbit is absolutely not normal on the normal side. There are volumetric changes that the involved side cause to the uninvolved side. We also see the classic V pattern, hypertrophy in primary, hypertrophy increasing in side gaze with fundus excyclotorsion. So I'd like to discuss quickly three main causes of this IO overaction, over elevation and adduction. The first would be extortion of the orbit, causes globe extortion. So the medial rectus is offset upward, behaving like an elevator in adduction, which causes a hypertropia. And the lateral rectus is offset downward, as you can see in these coronal sections, CT sections. The lateral should be at 9 o'clock, and the medial they should be horizontal one to the other. But in unicoronal synostosis, the orbit is extorted, leading to this globe extortion. And you can see the classic Harlequin sign on the CT scan upper right. Second cause would be superior orbital rim retrusion, which occurs in coronal suture synostosis. So you can see in the 3D reconstruction CT, the superior orbital rim is retruded. That causes a retrusion of the superior oblique trochlea, disadvantaging its function, causing a true underaction of the SO and secondary overaction of the inferior oblique. Number three, I'd like to discuss in more detail. Third cause of over elevation and adduction. So this is a child with Burt syndrome who I operated, and primary position, which I'm not showing you, was a small XT, but looking straight up, that the right eye looks like it's trying to get up, but the left eye, big, large left hypotropia, not elevating at all. This is not that hyper is not apparent in primary position. Looking to the right, it looks like there is left eye over elevation and adduction, and looking left, it looks like again there is IO overaction, over elevation and adduction. And you can see the grid below with the measurements, overaction of the IOs, underaction of the SOs, and underaction of both superior recti. So I look at the MRIs, and this sagittal section on the lower left, we see a very odd arcing pathway of the superior rectus. The superior rectus, as you know, should have a straight trajectory from the back of the orbit to the front of the eye. And it's got this odd arcing pattern, but it is, and it's a thin superior rectus, just a strange pathway. But on coronal, you really do not see a superior rectus levator complex. Looking at the superior obliques, which are underacting here, you can see a muscle belly there, right superior to the medial rectus, but they're small. So a thin small diameter. So this is another patient, very similar patient. I take the patient in the operating room, and this is the surgeon's view of the right eye superior, the eyes pulled downward. There's no superior rectus on either eye, and there's no superior oblique on either eye, despite the fact that the MRI showed an SR and revealed an SO, but thin muscle belly. So this is the third cause of over elevation and adduction in coronal suture synostosis, and that's agenesis of the superior rectus plus minus the superior oblique. That's a cause of true inferior oblique overaction. And as I did some data mining, there are about 8 publications I found, with a 3 or 4 page PubMed search, and all were associated with syndromic craniosynostosis. APER, craniofacial dysostosis, a term from the 80s and 90s, Pfeiffer syndrome, etc. Agenesis of the inferior rectus was way more published, over 20 publications. I kind of lost track. but not many associated with craniosynostosis. So here is a normal appearing coronal section T2. You can see a normal SO, a normal spirorectus levator complex. And another one of my patients, a coronal, I think APORT, syndromic craniosynostosis with hypoplastic spirorectus and superior oblique agenesis. So suspect EO, extraocular muscle agenesis, particularly of the SR and SO. So let's talk about how to manage the strabismus. So ET, XT, I think we all just follow the routine surgical nomograms and consider vertical offsets if there is a V pattern. That's never curative, in my opinion, on these patients, but additive. And expect the unexpected, because if there are muscles missing, vertical muscles missing that have as a tertiary function adduction or abduction, you may have an unexpected result. So, you know, these families are used to the unexpected. So telling them there may be unexpected results is not a problem for them. So warn of re-ups. The more problematic is how to manage the over elevation and adduction. So I've got a complement. I've got your a la carte list here. Lots of IO procedures. We get down to IO fixation to the orbital wall as extreme weakening. I mean, I've never done that, but it was on the list. Spiroblique tucks, Jonathan Holmes has published this in Craniosynostosis. But because of the retruded trochlear position, it may lessen the impact. I'm not going to discuss that here. And as I indicated, an additive procedure would be vertical offsets of the horizontal muscles for the V pattern, but never a home run there. So let's talk about the first two. Our most typical procedures, IO recession and IO myectomy. So I've got papers on the side here as references. So in the top paper comparing myectomy to recession for SO palsy, not in craniosynostosis, but SO palsy. I mean, we know this. The best results occur when the hyper is less than 15. I mean, I'd forgot, it was sort of urban legend, or that's how we were all taught in our fellowship. But yet we do have lower level evidence to show that, yeah, our gut is correct, that these procedures without craniosynostosis remediate and resolve vertical deviations with IO overaction if the hyper is less than 15. But, you know, if the vertical is over 15, you're going to get undercorrections with those procedures. And that was also borne out in this population by Pacey, Stager, and Coates from 2000, that inferior oblique recession and myectomy in, quote, superior oblique palsy associated with craniosynostosis, there's a high likelihood of undercorrections. And that's given the orbital abnormalities. So let's talk about some other procedures that are more powerful in correcting vertical hypertropias secondary to inferior oblique overaction or over elevation and adduction. So I found this top paper that compared three weakening procedures of the IO. I only discussed two. And it's comparing myectomy to anterior transposition, which you can see illustrated in the top as a typical procedure, illustration of the typical procedure for anterior transposition. So myectomy corrected in this study, as the previous paper and the previous slide, about 13 prism diopters of hypertropia in the face of IO overaction. 3% developed anti-elevation syndrome, and a small percentage, more than 3, developed inferior oblique underaction. And I think we've all seen that after myectomy. Looking at anterior transposition, it corrected 20 prism diopters plus minus 5 of hypertropia, but 13% developed anti-elevation syndrome. And we have our own Dr. Kushner to thank for coining this term and providing the most detailed explanations as to why it occurs. It is a limitation of elevation, especially in abduction, possibly secondary to excessive anti-elevating effect of the transposed inferior oblique. The force vector of this transposed IO may be greater in abduction than adduction, and hence restricts elevation of the abducting eye. And what does that do to the contralateral eye? Based on Hering's law, it causes over elevation in adduction or apparent contralateral inferior oblique overaction. So let's talk about a newer procedure that's not as well characterized, and that is of anterior and nasal transposition. The Stager-Beauchamp Felius group reported it a couple times now as a surgical management for patients with SO agenesis. It shares similarities to anterior transposition, reported to convert the IO into an anti-elevator in adduction, converts it into an intorter, corrects excyclotorsion in fundus excyclotorsion, and corrects obviously the hypertropia. But what about anti-elevation in this procedure? Well, the nasal, from what I understood, reading through the literature, the nasal modification was developed to prevent this complication. However, when I'm looking at these Stager group papers of their smaller group, 2 patients had an elevation limitation and torsional diplopia and upgaze. And in another paper from Dr. Fard, who's looking at this procedure, but for DVD and eye overaction, 1 patient out of 10 had a hypotropia in primary, which suggests to me these are anti-elevation syndrome patients. Another paper from the Dr. Sharma of 12 patients of this procedure in SO palsy. Average pre-op deviation was 21 with a range of, which got corrected down to 4. The range of the hypertropia was 12 to 36. So a powerful procedure for correcting a hypertropia, and reported no limitation of elevation. So we kind of have a mixed bag. I'm still not certain about that complication in this procedure. So I'm going to present my patient. Here is a adorable child with a marked cranial deformity due to a right unicoronal synostosis with right forehead protrusion, a Harlequin sign, elevated elevated and depressed superior orbital rim. And you can see here, he's looking straight ahead and he's got this whopping right hypertropia and an esotropia. So preoperatively, he's younger than he is now. He wasn't exceedingly cooperative, but looking straight ahead, this is the same photo, a right ET and a big right hypertropia, and my measurements are below. I think he has an occasional left face turn because he fuses, I think, in right gaze. Had a small ET there, but preferred, not strongly, but preferred a left face turn. So I take him into opposite gaze, into left gaze, and we can see this over elevation of the right eye in adduction. And the left eye doesn't look like it, well, it looks hypotropic, but I have to question, does it elevate? So I covered the right eye, and it appeared to elevate properly. So duction was greater than aversion, and that's why I graded it 0 there. Now I'm going to look at the CT scan or the MRI, but there were no MRIs, and there was a CT. It was for the 3D reconstruction, and I sort of saw the left superior rectus to make sure it was there and look at its volume compared to the other side. It looked okay. So my plan is to take the child to the operating room, perform exaggerated traction testing, and proceed with anterior nasal transposition on the right. So in the OR, I'm not that great with this exaggerated traction testing, but I feel there's right superior oblique laxity greater, but there's still some on the left, but right greater than left. So now he's a few months, maybe 4 or 5 months post-op in these photos. So looking in primary, he had what looked like a controlled deviation of a small left hyper. And so he used to be a right hyper, small left hyper with a small esotropia. He had mild, moderate astigmatism and mild hyperopia. I put him in glasses, and mom reports his ET is better. But he looks pretty good. So let's take him into left gaze where he had that whopping right inferior oblique overaction, and that got treated really well. So we corrected that procedure corrected over 35 diopters of right hypertropia, and it eliminated his inferior oblique overaction. So looking down, he's got a V pattern. I'm sure his superior oblique are underacting. Looking up, that's not such a great up gaze, but doesn't look limited, but look into right gaze. Now this is primarily what the parents see is this left eye over elevation and adduction. And is the right eye limited in elevation here? Does the duction equal the version? It sort of looked like that on our first exam. Is that anti-elevation of the right eye induced by this nasal and anterior transposition? Maybe. So my take-home messages are this. Inferior oblique overaction, these patients is multifactorial, more properly termed over elevation and adduction. Always suspect EOM agenesis or anomaly in patients with syndromic craniosynostosis. I don't believe it occurs nearly as frequently in isolated coronal suture synostosis, but it's the syndrome patients that are more at risk. And especially suspect this when there's limited ocular movement that does not improve on adduction or a one-eyed movement. Look at the MRIs or CTs preoperatively, but be cautious that the extraocular muscle that you see on MRI may not be attached to the globe. And absolutely, as all of us pediatric neuro-ophthalmologists know, do not ever rely on your radiologist to report accurately the status of anything, basically. Definitely the status of the extraocular muscles. Read your own scans. Make a surgery plan going in, but contingency plans if there are if the muscles you want to operate are missing. I would advise for standard surgical dosing for ET and XT, expecting the unexpected. And as for the surgery for the over elevation and adduction, hypertropia, V pattern, in this population, IO recession and myectomy will likely undercorrect if the deviation is greater than 13 prism diopters. Consider these newer procedures of anterior transposition or anterior nasal transposition. They correct larger amounts of hypertropia. They can get rid of whopping amounts of inferior oblique overaction. The range of hypertropia correction is about from around averaging 20. And I think both even anterior nasal transposition, as we know with anterior transposition, can induce anti-elevation syndrome. So be on the lookout for that. And thank you so much. Sorry about the delays initially.
Wonderful. Thank you, Dr. Edmond, for that fantastic talk. We are going to invite all the panelists to come back on screen for just a few moments and to answer any potential questions that we have in the Q&A. I just want to remind everyone to put questions in the Q&A section on the Zoom. We are typically using chat, but in this format, we're using the Q&A. And there is one question now from Dr. Wallace, and this is for Dr. Chang. Oh, I lost my question. It disappeared, but
there it's under answered. If you click on answered.
Okay, thanks. So it's wonderful that you are developing some new outcome measures for children with CVI. How will you go about validating these new measures?
That's a really great question. Thank you, Dr. Wallace. And actually, it was a subject of discussion at our last PCVI Society meeting last year. So the answer is we're trying to sort of copy what has been done in things like autism, where before there was really a diagnostic standard, because right now we have no gold standard. So one of the things we're doing is validating against sort of our qualitative assessment of their visual behavior in clinic, like how well they can fix and follow objects. Also, we're validating different methods against one another. So in addition to eye tracking, we're doing a functional vision testing with the CVI range, as well as sleep VEP. And we're hoping that using a compilation of all these different measures, we'll be able to get a better sense. But there is no great answer because there is no gold standard against which to validate.
Great, thank you. Dr. Heidary, I have a question for you. I was really intrigued by the contrast between patients who have more cranial nerve palsies as well, in contrast to the dorsal midbrain syndrome, and thinking about their ability or inability to fuse, and wondering if you have utilized prisms, or in addition to the surgery, as well as potentially using AD to help with accommodation in a bifocal, just to see if there was any change in their fusional capabilities.
Yeah, thank you. That's such a great question. Definitely, we explore the use of prisms postoperatively. And, you know, I think in those patients, for example, who had disruption of fusion, it's a scenario where even with like they're almost there, the prism gets them almost there, but they don't have kind of sustained fusion to make it work for them. And so, but definitely we try to employ that to see if we can get them close. The bifocals I haven't used yet. You know, what I'd like to do is more prospectively analyze accommodative function before we go in and operate, and try to understand the characteristics of this more in those patients. I think now I'm systematically doing the synoptophore for them, and I've been really quite surprised. I just did surgery on a young man I've been seeing for 8 years with a manifest XT, and I actually couldn't believe that he would have you know, fusion or stereopsis potential because his strabismus has been so long standing, but placed him on the synoptophore, and easily he demonstrated this potential, and just did his surgery, had great stereo after. So I think it helps me to at least counsel what I might be able to do postoperatively.
The variability in these patients is fascinating to me. How so unpredictable who will be able to achieve fusion and who will not be able to.
Yes, and then the question is like, how do we assess success? Because, you know, on the one hand, I think we can do really well in terms of motor alignment, so that's important, you know, for the social interactions and the reconstructive components. So I think we can be successful there, but then there are other elements of visual function that are harder to achieve. And so sort of that nuance and what we can offer patients, I think, has to be part of the discussion.
For sure. Very smart. We have a few other questions in the chat. One is wondering where the recorded video will be, and I think that it will, Ashley said it will be posted on the AAPOS website, but she can probably type in the answer exactly where. And then Paula Edelman asked Dr. Chang, is your criteria for timing of strabismus surgery different in kids with CVI versus kids without CVI?
Yes, in part, because we usually wait until the vision has improved, at least to the point where they can kind of fixate and follow faces or large objects before we offer surgery. There's no real evidence behind this, but we think that, you know, if they can't really see well, then there's no, you know, stimulus for their eyes to remain straight, so they'll just go out again. So it depends on their visual function. And then because as we know, some of these patients may not have that stable deviations, as with any child undergoing strabismus surgery, we wait until their deviations are stable before operating.
Great. Well, since we are a little bit behind schedule, I think we should move forward, and I'll introduce Dr. Pineles. So Dr. Pineles currently holds the Jerome and Joan Snyder Chair in Ophthalmology at the University of California, Los Angeles. She is an internationally renowned academic pediatric and neuro-ophthalmologist with longstanding interest in clinical trials of strabismus and surgical techniques and outcomes, as well as pediatric neuro-ophthalmologic conditions. She is currently the chair-elect of the Pediatric Eye Disease of PDIG, which is a collaborative network dedicated to facilitating multi-center trials, as we all know. Dr. Pineles received her bachelor's from Duke, her medical degree from the University of Pennsylvania. She completed her ophthalmology residency and pediatric ophthalmology fellowship at Jules Stein Institute at UCLA. She then completed a second fellowship in neuro-ophthalmology at the University of Pennsylvania and the Children's Hospital of Philadelphia. She was awarded a master's degree in clinical investigation from the UCLA Department of Biomathematics in 2013. As her career has progressed at UCLA, she is now the residency program director. She is currently the president-elect of the AAPO Program Directors Council and the chair of AAO's Ophthalmic Technology Assessment Committee, as well as the AAPOS Research Committee. She has a lot of roles. She is the recipient of numerous awards, including the AAPOS Young Investigator Award, the AAO Secretariat Award, and the AAPOS Honor Award. Dr. Pineles has published over 140 peer-reviewed articles, 12 book chapters, and has delivered numerous international lectures. She's a superstar. We are so excited to hear her talk entitled Functional Burden of Strabismus and Binocular Function.
Okay, I'm back.
Okay.
Okay, let me share my screen. Okay, yeah, everyone can see my screen now, right?
Yes, I can see your screen, but it is on. There you go. Perfect.
Okay. All right, here we go.
Thank you very much. I'm so excited to be here to deliver the Kushner webinar lecture for 2023. I want to start by acknowledging Dr. Burt Kushner, who we all know and love. Dr. Kushner has a very prolific and extensive career and CV, and I'll just highlight his background in that he graduated from medical school from Northwestern University, and then he had his residency in ophthalmology at University of Wisconsin, fellowship at Bascom Palmer, and then from 1974 until now, he's been on the faculty at the Department of Ophthalmology and Visual Sciences at University of Wisconsin. And they're so lucky to have had him for so long. He currently serves as a professor emeritus of the Department of Ophthalmology. Just to summarize a career that is not summarizable, Dr. Kushner has published 208 peer-reviewed manuscripts, 41 textbook chapters. He's edited 3 books and authored 2, and delivered at the last count 26 named lectures. The unmeasurable part of his career is the number of patients and physicians that he's touched by his knowledge and skill, and most importantly, his generosity in sharing of his experience and intelligence. All of us have benefited from Dr. Kushner's research and knowledge. He answers the AAPOS listserv. He speaks and gives comments on lectures and thoughtful emails on lectures that I've delivered, and I'm sure many of you have as well, and papers. And he's also reviewed many papers and written many papers. So every single one of us has really benefited from him. My own experience with Dr. Kushner started in 2009 when I was in my pediatric ophthalmology fellowship with my mentors at UCLA, Dr. Eisenberg, Dr. Diemer, Dr. Rosenbaum, and Dr. Velez. And Dr. Rosenbaum, who unfortunately passed away way too early, was one of my main mentors. And he used to speak about a mysterious Dr. Kushner at least once a week, referencing his research or something he had said to him once. In my mind, he was kind of like the Wizard of Oz, like this hidden strabismus wizard in the middle of the country. And he was the go-to expert for Dr. Rosenbaum, who was one of my go-to experts. So I just sort of always by transference, or at least that's how I felt. And I've always appreciated the time that I've been able to spend with him at meetings, at Squint Club, and throughout my career. So thank you to Dr. Kushner for everything you've done for our field and for allowing me to participate in this webinar. I want to acknowledge the prior Kushner webinar honorees, nice international crew of people here. Last year, Dr. Goldschmidt delivered an amazing set of lectures, and I will be speaking today.
I'm just going to interrupt myself and say that last year, actually, the speaker was Dr. Stephen Archer, who delivered an amazing lecture. I was using an outdated list and didn't realize we were in 2023. So let's add Dr. Archer to that wonderful list of speakers and then go ahead with my talk.
So many of you have probably heard me talk about some of these topics, but I'm hoping to sort of collate all of the topics that I'm interested in into a single lecture. I apologize if some of this is redundant for you, but hopefully some of you who are younger or newer to the field will get something out of this. I want to acknowledge the research funding that I have that has supported most of this research. So we all know here, we're all interested in strabismus, and we know it's relatively common, occurring in 2 to 5% of the population. Patients with strabismus do tend to close one eye sometimes, even if they don't have diplopia. And that observation is what sort of led me down a path of trying to understand the visual experience of patients with strabismus. And we know from that sort of thing and other ways that patients tell us that they can't see well, that our understanding of the functional binocular vision in patients with strabismus is not as good as our treatment, which is pretty decent, strabismus surgery or glasses or whatever. When we think about binocularity, we think about stereopsis as an advantage, visual field normalization. And then I'm going to focus on binocular summation for the first part of this talk. And the second half, we'll talk about some other stuff. So binocular summation, if you don't already know, is defined as the superiority of binocular over monocular performance on visual tasks due to a combination of the inputs from the two eyes in the brain. So what I mean by that is with your two eyes open, you see better than with one eye alone for many visual tasks. In normal subjects for low contrast acuity, this binocular summation or binocular improvement with the two eyes together is about a factor of 1.4. So that means that patients see 1.4 times better with both eyes open compared to the better eye alone. We can define binocular summation either as a ratio or a difference. And in some of the research I'll present, I've defined it both ways. So let's just make sure we're all on the same page here. If you calculate binocular summation as a ratio, you're going to take the binocular score of whatever your test is. So if you're doing ETDRS letters, you might have like 60 letters, and then divide that by the score of the better eye. So if with two eyes open, you saw 60 letters and one eye you saw 50, then the ratio would be in like 1 point something, and that patient would have binocular summation. On the other hand, if the binocular score is low, like 30, and the better eye alone saw 60, then that ratio would be 1/2. And that would be a number less than 1. And that means that the binocular score is worse than the better eye alone. So in that case, both eyes open actually make the vision worse for a patient. We call that binocular inhibition. And that's not normal. Binocular inhibition is a pathological state. Same thing, you can do it as a difference. If the binocular score is higher than the better eye, when you subtract it, you're going to get a positive number. That's summation. If you get a negative number, that's inhibition. So a lot of studies have looked at binocular summation. Most commonly, it's evaluated using high contrast letter charts, which is not a great way to look at binocular summation. Two large studies that were epidemiological studies related to visual acuity were the Los Angeles Latino Eye Study and the Salisbury Eye Evaluation. And in these patients, when tested with high contrast letter acuity, there really wasn't much summation or inhibition in those patients. And that makes sense because binocular summation is actually something you see much more in low contrast settings or anything where there's noise in the system. So low contrast, motion, that sort of thing is when the two eyes working together is really important. So on a clear day in Philadelphia, where I'm from, you can see the Rocky statue probably with one eye, both eyes, it doesn't matter how you're looking at it. But on a really foggy, snowy day, you will see better with your two eyes open than with one eye alone because of binocular summation. So we know that aside from the visual task, there are various factors that increase the sort of noise or static in our visual system. And the most commonly quoted ones are age and interocular difference, meaning the visual acuity in one eye is very different than the other eye. Those things decrease binocular summation and increase inhibition. So if a patient has a cataract in one eye and they're like 20/80 and the other eye is 20/20, that might cause them to have less summation or more inhibition. So a lot of research has looked at this with age to try to evaluate how this affects elderly patients' visual function. And what they found is that when people who are elderly, over 70 or so, look with the two eyes open compared to one eye alone, they actually are much less likely to have summation and more likely to have inhibition. And this is independent of the difference between their two eyes in terms of visual acuity. So older patients are more likely to have binocular inhibition. When we increase the difference in visual acuity between the two eyes, we also increase the risk of inhibition. So if you have a cataract in one eye that's causing glare in one eye, or if you have defocus in one eye, like for example, if you're using monovision, then you can have binocular inhibition. So to demonstrate that, I'm going to show you this graph here. This is when we induce spherical defocus in one eye. So if we make someone have monovision. So here, if we don't have monovision and the difference between the two eyes is 0 diopters, or both plano, for example, and you do a visual task, you have binocular summation of a ratio of 1.4, which is normal. As we start to defocus one eye and make it +1 or +1.5, you see that the summation ratio is decreasing. And around 1.5 of defocus between the two eyes gives you a ratio of 1. So when you defocus one eye for monovision, after +150 of difference, you actually can get inhibition. So let's say you have someone doing monovision that has 2.5 diopter difference of vision between the two eyes. That patient is much more likely to have binocular inhibition. And when they're looking at a low contrast acuity chart, they may want to close that eye that's corrected for near. As you get more and more defocused, the ratio gets closer to 1, because at some point the eye is so defocused that you're basically just using the one eye alone. So interocular difference is a really key factor when it comes to binocular summation. Unilateral cataracts, monovision, those are 2 examples of times where this occurs. So what we're going to talk about now is how does strabismus affect a patient's ability to have binocular summation. We know that strabismus causes images to fall in a non-foveal area of the deviated eye, and that might lead to sort of a degraded or suppressed image being a way to sort of think about inducing an interocular difference in visual acuity between the two eyes. So some of the studies that I'm going to present now have tried to look at whether strabismus causes abnormalities in summation. So the first study that I'm going to talk about is an older study that I did with my group here at UCLA and others, where we took 60 patients with strabismus and 80 control subjects and tested one eye and two eyes using high contrast and low contrast charts. And what we excluded patients with amblyopia or other causes of interocular differences. And we calculated binocular summation. What we found, this was published like about 10 years ago at this point, was that the patients who were strabismic, about 30% of them had diplopia, the rest did not. And the age and visual acuity between the two groups was pretty similar. When we looked at the different visual acuity tests, which are shown here at the bottom, what we found was that the 2.5% and 1.25% Sloan low contrast acuity charts were the best at evaluating for binocular summation. Those are just ETDRS charts that have varying levels of contrast. So in the control patients, when we tested the two eyes together versus the better eye alone, we got 5 letters or 1 line of binocular summation. They saw better with both eyes open. But when you took the average of letters of the strabismus patients, there was no improvement with the better eye alone. So some patients had summation, some had inhibition. On average, there was no summation. And this was very significantly different between these two groups. So we really started to see that strabismus affected a patient's ability to have binocular summation. When we look at the data in a different way, where we're looking at how many patients have summation, meaning 1 line or more better on the eye chart with the two eyes open, we found that almost all of the control subjects had summation for the low contrast Sloan charts, but only about a quarter of patients with strabismus did. So this shows us that strabismus really did affect a patient's ability to have summation. And even more interesting, when we did the same thing but looked at the percentage with inhibition, we found that controls barely ever had binocular inhibition, but strabismus patients, almost half of them did at low contrast. So these are the patients that are closing one eye because they can't see as well in low contrast settings due to their strabismus. I think I sort of just described these conclusions. And this really was a way for me, at least, to start to understand the functional deficits caused by strabismus in the real world setting, especially when there's no double vision and you're trying to figure out how this affects patients' vision. So the next question really was, how does this affect our patients? And so we looked at a group of patients with strabismus and did some quality of life questionnaires to evaluate whether the presence of binocular inhibition was associated with any abnormalities on the National Eye Institute Visual Function Questionnaire. We corrected for other covariates like age, double vision, gender, sex, visual acuity, and we found that there were several subscales on the quality of life instrument that were affected independently by a patient's ability to have binocular summation or the presence of inhibition. And those included things we might expect like driving, distance, and near activity. So it really does seem to affect patients' quality of vision in life. And then we started to ask ourselves, well, if this is affecting our patients and we're doing strabismus surgery, how does that actually affect the patient's binocular summation? So here we took 90 patients who were undergoing strabismus surgery and tested them before and after surgery with just the slow and low contrast charts and the high contrast ETDRS chart. We calculated binocular summation, as I already mentioned, as a difference between the two scores. And this was published about 7 years ago. And the patients, there were 90 of them ranging in age, from 3 to 90 with normal visual acuity, a wide range of strabismus angles, and a little less than half of them having diplopia. So this chart is a little confusing, but maybe just ignore the bottom half for now and look at the 90 patients. These were their summation scores pre-op. So before having strabismus surgery, there was on average, not much binocular summation, a little bit, but not much binocular summation for the 2.5%. And at the lowest contrast, on average, patients actually had binocular inhibition. Then after the surgery, we looked at their binocular summation, no significant change in the ETDRS chart, which is sort of serving as a control. But in the low contrast groups, we had a significant improvement in binocular summation scores for both contrast levels. And the lowest contrast level on average went from binocular inhibition to binocular summation. 1 year at AAPOS, when I presented this, somebody asked about what if you only looked for patients who were successfully aligned? So out of 90 patients, we had some success criteria, 75 met it, and the findings were pretty much the same. That's what the bottom half of this chart is showing. If we look at the proportion of patients that had summation and inhibition, the green is pre-op and blue is post-op. I'll just focus on the lowest contrast to keep it simple, but the other contrast shows the same thing. Pre-operatively, only 11% had summation and post-op 21%. So the strabismus surgery caused a doubling of the proportion of patients who had binocular summation. And similarly, pre-op, about 20% had inhibition, post-op, almost 10%. So half the patients who originally had binocular inhibition improved to having no inhibition. We looked at this by strabismus subtypes, and we found that the greatest improvement or switch from inhibition to summation occurred in patients who had fused in the past, like intermittent exotropia, acquired strabismus, and congenital superior oblique palsies. Those patients who had infantile or very early onset esotropia were the least likely to improve, and some of them even got worse when we lined up their eyes. So at the lowest contrast level, doing strabismus surgery seems to improve binocular summation, and about half the patients had half the patients who had inhibition originally had it post-operatively. More than a quarter of the patients had improvement by one line, so 5 letters of their binocular summation score after surgery. And I already mentioned about how patients who had previous fusion had the most success in terms of regaining binocular summation. And those with early onset strabismus actually may have been made a little bit worse by realigning their eyes, just in this one metric of binocular summation. But certainly in other areas, repairing infantile strabismus is certainly very crucial. There are a few other papers about this topic that I just wanted to share with you if you happen to be interested or want more information about specific diseases and binocular summation. But now I'll move on to how these findings sort of apply to patients and how strabismus affects patients in terms of their systemic health and morbidities. So because of the fact that we know that binocular summation is affected, or binocular inhibition is increased in patients with strabismus, and those patients often do tend to have diplopia or abnormal depth perception, we thought it would be interesting to look at elderly patients who have strabismus to determine if they're at increased risk of injury. And the easiest way to do this is to look at it in the Medicare database. And so with Michael Repka and Ann Coleman and others, we were able to evaluate the Medicare database and look at the odds ratio for different types of injuries in patients with strabismus diagnoses. It's a little bit tough in patients who are elderly to really isolate the contribution that strabismus might have because of all of the possible covariates. You can see all of the things we corrected for age, sex, race, all these conditions here, plus their Charlson Comorbidity Index score, which is a sort of score that tells you the chance of death in the next certain number of years. So it sort of just gives you like an overall sense of what their health is like. So all of that was taken into account. And what we found was that just having strabismus, after adjusting for all of the other factors, increased the elderly patient's risk of fracture by 24%, fall by 20%, and another type of musculoskeletal injury by 23%. So these patients who have Medicare, if they have strabismus, overall, their risk of any of these types of injuries was 27% higher than their counterparts without strabismus. And we don't know what's to blame, whether it's binocular inhibition or, maybe just the number of them that had diplopia outweighed the rest and caused it. And there have been similar studies that have looked at other eye diseases like macular degeneration and glaucoma. And the impact here actually seemed more profound, higher odds ratios. But of course, we can't really make a direct comparison between different studies because of the difference in methods. So after we did that study, we were really interested in knowing if children with strabismus are at increased risk of injury. There's not as good of a government database as there is for Medicare beneficiaries for children. So we took the next best thing and looked at the Optum's claims database, which is a large database of United Healthcare claims. And what we did was we looked at the risk of physical injuries in all types of pediatric eye diseases. The most common disease we found was strabismus, 58%, a lot of children with amblyopia, and then other diseases were less common. When we looked at this database with about 11 million kids, it turned out that 10 million of them did not have eye disease, and 725,000 children, or almost 7%, had one of these serious eye diseases. Now, in this study, we're not talking about refractive error. We're talking about medical diagnoses. And what we found when we did a similar study looking at covariates and all of the things that I explained in the Medicare database was that in the eye disease group, there was a significant increased risk of all of these types of injuries compared to controls. And this is before we corrected for covariates. So children with the serious eye diseases had a 29% risk of having an injury, whereas the other children, 23%. So it's not a huge difference, but when you're talking about 10 million kids, 6 or 7% is actually quite large. Musculoskeletal injury, fracture, head injury, and eye injury, all of those were double or more. When we decided to look at the same risk factors with adjustment for covariates, what we found, let's look in this column here that I'm showing you with my arrow, because this is adjusted for all of the covariates I discussed. We found that there was an increased risk in children with eye disease of injuries, but not as high as an adult. So for example, there was a 16% risk of fractures when a patient had an eye disease after adjusting for all of the other covariates. The only number that was a lot higher was eye injury. And that's one thing that's kind of interesting to me, because we always tell parents when you have poor vision in one eye, you have to wear polycarbonate glasses to protect the other eye. And this really lends credence to that. Now, we know that these patients with eye injury diagnoses could have had an injury to their eye that already had a problem, and that's what they're being coded for. We tried to minimize that by only taking patients who had their eye injury coded for after their other eye disease was coded for, but we can't be so sure. So it's probably less than 63%, but it's definitely elevated and does lend credence to the recommendation to always protect the good eye. When we did some statistics to evaluate how many pediatric injuries in the ER based on demographics that we got from the government, we were able to determine that 740,000 pediatric injuries are attributable to eye disease annually. So basically, based on these hazard ratios, we could say that if none of the children had eye diseases in the country, we would have 740,000 less injuries per year. So it's pretty significant. When we looked at specific diseases, nystagmus was one of the more common ones to be associated with injuries, and amblyopia, glaucoma, esotropia were much less commonly associated with injuries. And I think maybe one reason for that is some of these diseases, when coded for, can have a very wide range of severity. So you could have an amblyope who's recovered or have 20/25 vision and still be coded as amblyopia. You could have a fully corrected accommodative esotropia patient coded for esotropia. You could have, a glaucoma suspect with enlarged discs coded for glaucoma. So these are, the limitation here is that this is based on coding. And then we asked a similar question to what we asked in our binocular summation study, which was, what happens when we treat the eye condition? Does the risk of injury lessen? So we looked at patients who had strabismus for this, or strabismus surgery, versus those that had similar diagnoses but did not have surgery. So in this huge database, only 26,000 patients underwent surgery versus their counterparts that we use as a control group who had strabismus but no surgery, and there was 318,000 of them. So the risk of the patients who had no surgery was about 30%, and those who had surgery, it decreased to 22%. Again, a difference of about 8% isn't huge, but it's statistically significant. And when we're talking about such huge numbers, it probably is really something to be interested in. Looking at the various types of strabismus separately and looking at the adjusted, remember, we're doing adjusted because of all of these covariates that could affect the risk of injury. When we look at all the patients who had strabismus surgery, the adjusted hazard ratio for injury after surgery was 0.85. So the risk of injury decreased by 15% after adjusting for covariates. And this was most significant in exotropia, 18% decrease in injury risk, and less in esotropia, 9% injury risk decrease. Just to sort of wrap things up a little bit, I wanted to sort of shift gears. We talked about binocular summation as a way of understanding how binocular function is different in patients with strabismus. And then we moved along to talk about these studies looking at injuries in patients with strabismus, adults, kids. We also found that we also looked at other serious eye diseases in children, with cataracts, glaucoma being examples, and found that those patients were also more likely to have injuries. What we did, the last thing I want to talk about is to tell you about the last study that we've been working on with this data set, which is to look at mental illness in children with strabismus and with eye diseases. Now, this isn't directly related to the injury study, but it's another way, it sort of all links together because it's another way of trying to understand how pediatric eye diseases affect our children systemically. And so this table is from a recent publication where we looked at mental illness in the children from the Optum database, the same ones we used to look at injuries. We looked at mental illness in children with strabismus and those without. So first table here is patients with strabismus and then the controls who have no eye disease. And we looked at some common mental illnesses that we expect to see in children and adults. And when we compare the percentage of these diseases, what we found was that anxiety, was the most common mental illness in strabismus patients. 11.6% of the patients in this database had anxiety, whereas in controls, it was only 6%. So it's almost double the percentage of patients with that diagnosis. Depression was more common, bipolar disorder was more common, and schizophrenia was more common. Those three disorders were a little bit less striking, but still more common and with significant multi-variable adjustment odds ratios. Substance abuse, which isn't very common in kids at all, happened to be less associated with strabismus, meaning the odds ratio was less than 1, although it crossed the 1. The reason that I'm bringing this up is just to show, sort of to talk to the critics of people of a paper like this who will say, well, anytime you have two huge groups, 350,000 versus almost 12 million, everything's going to be significant. So maybe this 11.6 versus 6.4 isn't really such a big difference. It may not be significant. These numbers are huge. Every p-value is going to be low. Well, what we're showing here is that when we did the same thing with this other specific psychiatric disorder, it actually wasn't significantly different. So I think that sort of shows that these other 4 disorders, anxiety, depression, bipolar, and schizophrenia, may actually be truly associated with a higher incidence in patients with, in this case, strabismus. So to conclude, patients with strabismus often have complaints that are difficult to characterize. Our data suggests that strabismus patients have decreased summation and may have inhibition. This represents some further understanding into the functional deficits caused by strabismus in real-life settings, especially in adults who we used to think were just having psychosocial consequences if they didn't have diplopia. This sort of line of reasoning provides further evidence that there are functional benefits to strabismus surgery beyond stereo acuity, visual field, and psychosocial concerns. Because of summation and stereo and diplopia, we now know that disorders of binocular vision are associated with a higher risk of injury in elderly patients as well as children after accounting for confounding variables. And the risk is similar in children, with the highest risk being in patients with nystagmus and amblyopia being the lowest. And then lastly, I talked briefly about mental illness in these patients, and we've just published a few papers that have shown a real increase in mental illness in patients with strabismus of all types, as well as in serious eye diseases like cataract and glaucoma. Anxiety is by far the most common mental illness in patients with all of the eye diseases, followed by schizophrenia, depression, and bipolar disease. So thank you very much for your attention. We'll talk live now about this talk and anything else that we want to discuss. Thanks again to Dr. Kushner and to all of the speakers.
Thank you so much, Dr. Pineles, for that fabulous talk. It was a great summation of all of your valuable research and really can change the way we think about who and why we treat for strabismus. Next, Dr. Kushner, we would love to hear your thoughts and comments about the lecture and the award.
Thank you. Well, I was so excited for this webinar, and I must say, my excitement, I feel fulfilled. Congratulations to the entire crew, the panel, Gena, Melinda, Jane, and of course, Stacy. I learned so much in this webinar, and I'm sure everybody else did. Stacy, you did a fabulous job as always and as expected. You will be receiving an honorarium, hopefully shortly, and you will be the recipient of the medal, which for those who haven't seen it, I will put up here. It has on one side what is supposedly a likeness of me. I don't know, they have me wearing a coat and tie, so they may have used someone else as the model for that, I don't know. And on the flip side is the logo of the great University of Wisconsin. I want you to know, I think I mentioned this to you and for those in the audience, no one has ever contracted COVID. while wearing this medal. And I might even say if you wore it on your flight to Austin, you may not have even gotten the cold. But seriously, you now join the list of 7 prior recipients of this medal. You're now number 8. I will say that when we started this 8 years ago, I knew that someday this day would come when I'd be presenting you with this medal. And it's really been an honor for me. So I thank you, and I thank the entire panel.
Thank you so much, Dr. Kushner, and to all of the panelists. This was really wonderful and the biggest honor I can imagine. Thank you.
Well, I want to thank everyone for attending the 8th annual Kushner webinar. If you missed something or want to hear a lecture again, a recording will be available on the AAPOS website shortly. We hope to see everyone at the AAPOS annual meeting in New York City on March 29th through April 2nd. Thanks again.